Thank you, Dr. Sharda Jain, ma'am, for inviting me and the team of Delhi Forum East, and of course, Achimentis Harmonica for having brought me here. As I have a lot of respect for Sharda, ma'am, and all of you for sure, but I have known her for many, many years. I equate her to my own teacher, Dr. Padma Rao from South, and whenever I see madam, I get a lot of enthusiasm to speak to the people who want to listen to me. And I was just telling them, I'm not standing for any post of Foxy. I've just come on my own to just be amongst you all. I was thinking, I'll take you through certain of my clinical experiences of fibroids and what we can do and what we cannot do. I think surgery is necessary, but not for all. That's what I want to start with. We should know when to diagnose things for a surgical aspect and when to do a medical aspect, because we have medical aspect as well. I bring greetings from Manipal University from Karnataka State. I am the senior consultant in the Department of Reproductive Medicine and Surgery. I started this MCH courses 3 years back. We have 3 candidates per year coming in for MCH in Reproductive Medicine and Surgery, and we are one of the 8 centers in India, and Karnataka has only 1 center, that is Manipal. And that's why I've come from South India, south, very close to the Arabian Sea, little down south of Mumbai and Goa. Now, people who have a lot of pain, especially adolescent pain, menstrual pain, and they have heavy menstrual loss, we should only think of 2 things. It's either fibroids or endometriosis. There are other reasons, yes, but generally there are only 2 things. Now, I had a patient with severe pain, adolescent girl. She was so, I was telling madam, my wife, though she's not a doctor, she does a lot of social service to talk about menstrual hygiene and menstrual. So one of these young girls came to her and said she has a lot of pain during menstruation. She's bleeding a lot. So then she told me, can you look at this girl? Then I realized she has a fibroid, a young 16-year-old girl having a fibroid. But of course, what did I do? I did not do anything surgically. I just started medical management for her, especially mifepristone, and her pain went away, and menstruation also became very less, and she was amenorrheic for some time. But these are the little evidence to say that one should take a proper history, even in the social services when we do, and of course in our own practice. Now, FIGO has classified beautifully like this. We don't say it anymore, we don't talk about subserous, intramural and submucous. That's the easy way to talk about. But I think when we talk about fibroids, we talk about FIGO classification. See, what is inside the 0, 1? Everybody knows. 0, 1, 2 is all in the 0 is basically pedunculated, and 1 is 50% intramural, 2 is 50% more than intramural, means it's all projecting into the cavity. But what we should also know is the FIGO 3 and 4, which I'm going to talk about, are actually the one we're talking about intramural. The others all become submucous. When it is around 5, 6, they are all about subserous. We were always taught subserous ones doesn't matter at all in infertility, but I'm going to talk about it a little later. This is a patient whom I had, another patient. She had severe dysmenorrhea. The same patient as another one, her friend this was. She had 4 consultants said there is no lesion by ultrasound. And I did a TVS on her. Of course, she was not a young girl. She was married girl around 20 years now. And I found a very small 1 centimeter corneal fibroid. And that was causing pain because abdominal ultrasound missed that corneal fibroid. And when I did the transvaginal sonography, I picked up, and we were all taught the cornu is a pacemaker in obstetrics, labor pain starts from there, etc. That must be the lesion where it is very, very sensitive area. So 1 centimeter, how can I go and remove that? I can't. I just started Mefi just for her, 25 milligram per day. I gave it for 3 months, out of the box thinking, and her pain disappeared, and I found there is no symptoms later, and the fibroid I could not see at all after 3 months, because the whole thing was just 1 centimeter, and you'll find after 3 months it disappeared. So I think the role of mephigest in these kind of patients are very, very important, because you go and operate the little 1 centimeter, you won't find that also properly in the laparoscopy also. So I think the clinical scenario of medical management has changed by choosing the patient, and this patient was forever thankful to me for having brought down her pain and dysmenorrhea. So the role of mifepristone is important to understand. But another patient I had, she was 40 years, posted for hysterectomy by one of my neighboring doctor friends. The uterus was just around bulky 8-week size. I found 3 intramural fibroids of 6, 4 and 3, the figure 4 and 5 kind of a classification. There were 3, around 6, 4 and 3. This one patient did have menorrhagia, excess bleeding, but she did not want surgery. She was very young, 40 years. I too felt at 40 years one need not operate, because in 3 years' time the ovaries will go away and she'll get into menopausal problems of fractures and heart attacks and so on. So I just gave her the choice of Mefigest for 3 months, and in 3 months she was very anemic. Obviously she didn't bleed during mifepristone treatment, and her menorrhagia stopped and anemia was better. Hemoglobin was around 11-12 grams, and after about 3 months I found there was almost 40% reduction of the fibroid, and I continued for another 3 months, and the repeat TVS actually showed a very good response of, see, these medication never become zero fibroid, it'll always be there. At least it moves away from that submucous area and the corneal area, and probably the pain becomes better. So there is definitely, this patient did have symptom relief with mifepristone, and no further medications are given, and after 6 months actually I stopped it. Then I said, you come back if there again a pain, because we have found now by giving mifepristone, after 6 months they get endometrial hyperplasia. This is my experience. Even the book says that. Now, I used to do biopsy for all endometrial hyperplasia, but now the literature says if there is 6 months later mifepristone and hyperplasia, there is no need to do biopsy. You just stop it and she'll get back a menstruation. So I was doing everybody biopsy, and then I found nothing wrong in that. So this is what we should understand. Beyond 6 months, if there is a good relief, continue. If there is endometrial hyperplasia by ultrasound, you stop it. Another 3 months you stop. If symptoms comes back again, maybe you can decide about the further role of management. Over the years we realize the estrogen and progesterone is the main culprit of the fibroids, but more important is fibroids overexpress estrogen and progesterone receptors. So over the years we realize progesterone receptors are also the major culprit of fibroid, and it's not only estrogen. So we found a lot of publications came up over the years saying that progesterone plays a vital role in promoting uterine growth of the fibroids. Progesterone receptor binding is 3 times higher in fibroid as in the myometrium as well. So we also knew that progesterone has dual action on fibroid growth. It stimulates a lot of things happening there. Basically, you should understand there is some protein being expressed more, and EGF also is expressed, and tumor necrosing factor is reduction. So basically, when you find the inhibition of apoptosis occurs, angiogenesis increases, and fibroid cell proliferation occurs, when you give mifepristone, all these will be opposite action. So progesterone in fibroid pathogenesis, progesterone and progesterone receptor are indispensable to tumor growth, increasing cell proliferation and survival, and enhancing extracellular matrix formation. In the absence of progesterone and all these receptors, the things go on off track. So progesterone signaling in fibroid pathogenesis does affect all these vascular changes and of course the receptor changes, and there's a good response by medical management. Now what about infertility? I think infertility is an area where surgery is a upper hand. Supposing there's myomas and she's infertile, I think surgery plays a better role than medical management, unless you want to postpone, like the husband is in Dubai, wife is in Delhi or Manipal, and he's coming after 6 months. Then probably in those cases you will give medical management for symptomatic relief, or just for fertility I don't think it matters, because you have to remove it most of the time. Now in which case medical management will help, which I am going to show you. The current literature calls for removal of submucous fibroid and possibly cavity distorting intramural fibroids to optimize pregnancy outcome. However, removal of a non-cavitary distorting fibroid like the figure 3, figure 4 I was talking about is always controversial. We were always thinking that need not be removed. But in infertility, I'm going to tell you why in certain cases we may have to remove or give medical management. So the question is, does intramural fibroid cause infertility? Does myomectomy improve outcome of the pregnancy? Are there any alternatives? Once again emphasizing that this classification very, very important. Sometimes there will be a big one. Can you see this one here? That is called a 2 to 5. It may be projecting to the cavity, but also going outwards. A big fibroid, 2 to 5 is classified. That also can create fertility problems. So you may have to remove or probably give medical management in certain cases. Now, why is important to know is, we once thought that fibroid never causes infertility unless it is submucous. But now, because we have seen pregnancies with fibroid any number of times. But now this infertility and fibroids are connected because they have studied more on this implantation gene called as HOXA10. This HOXA10 is for uterine receptivity. In our clinical practice, we don't do all that, but literature says that. Endometrial tissue from women with intramural fibroids showed a trend towards less HOXA10 mRNA, which was not statistically significant by some studies. But 3 months after myomectomy for intramural fibroids, HOXA10 and 11 expression in endometrial tissue has also been shown to increase 12 times or 9 times. That means removing of the fibroid, now the thinking is anything above 4 centimeters in infertility, it's better to remove. If it's not the subserous one, the rest of them probably have to be removed. Subserous is a different variety, the Figo 5, 6 kind of thing. If they're within the myometrium, madam is doing IVF. I have one patient I'm going to tell you next, ma'am, what I did. Now, intramural fibroid, looking at that, lots of changes are happening in the body, in the uterus and in the endometrium. That is why the receptivity goes down, with especially the Figo 3 and Figo 4 fibroid. I repeat what I said. Figo 3 is very close to the cavity but not distorting. Figo 4 is in the myometrium but little away from the cavity. So now we are thinking about diagnosing Figo 3 and Figo 4 in infertility. Whether to remove or not is the question. Now this is important to know in a person who does IVF and embryo transfer. The junctional zone is between that myometrium and the endometrium. The junctional zone is the innermost layer that immediately abuts the endometrium, may affect fertility by 2 different mechanisms. Origin of myometrial peristalsis and the disruption of this zone may lead to myometrial changes. They have found a lot of activity in the muscle. They have found contractions occurring. That's why in embryo transfer, when you put it, will push the embryo away. So, may cause thickening or disruption of the junctional zone, leading to poor reproductive outcome. Now, this is important to know here. The junctional zone, I think this is what I said. Okay, I didn't show you that, but I'm going to show you the next one. Yeah. This is important. If you look at this here, this is Figo 3. That they have found now by doing cine MRI, forget MRI, they've done cine MRI is moving, I believe. They have found movements of the muscle during embryo transfer if there's Figo 3 and Figo 4 myomas. The first is focal or sporadic bulging of the myometrium. The second is the rhythmic and subtle stripping movement in the subendometrial myometrial causes high frequency peristalsis. So it's important to know, if you diagnose 3 and 4 fibroids and it's for embryo transfer, if you have failed one embryo transfer, you should think twice. Should we do that again? See, first time we may try. If there are enough and more embryos, we don't transfer again. I would like to remove them and then only transfer. But now I have found, this is one interesting patient, ma'am, I just put it here. She was only 34 years with failed IVF outside, history of myomectomy twice, both laparoscopic methods, and presented for another attempt under my care, IVF. I found only that Figo 3 again. TVS showed Figo 3 classification of fibroid, very close to cavity, only 2 centimeters. I did not want to remove that because to get that 2 centimeters in a laparoscopy also maybe is easy, but why do a laparoscopy, I thought. This is one of my patients, I started Mifepristone. I just started Mifepristone because failed outside before I did my own embryo transfer, gave for 3 months, and the fibroid reduced to small, maybe 0.5 centimeters, 1.5, but it became Figo 4. This is called as migration. So it became from cavity junctional zone to a little inside. Then I transferred the embryo the next month, after a couple of months later. I wanted her to get menstruation. When you give mephi, they don't get menstruation. So when she got the menstruation, I said that month I'll transfer, and she was successful. She has delivered a baby now. So when 3 failed IVF, you find out why we are going to fail again. This Figo 3 and Figo 4 can be given medical management for 3 months and make the Figo 3 become Figo 4. This is again out of the box thinking. No guideline says that, no book says that. It's our own clinical experience to share, because that's how out of the box thinking becomes maybe a attraction to put it in a guideline somewhere. Now, hence, animal models have proved that both HOXA10 and glycodelin, one more implantation, were reduced in implantation studies, but again not conclusive. They have found some more to make it more confusing for us. They have also found bone morphogenic protein. See how much of research is going on. A growth factor regulating cell proliferation and differentiation found to be critical for endometrial decellularization. Endometrial stromal cells isolated from 12 women with either submucosal or intramural fibroids were found to secrete 3-fold less BP2 than, of course, health control. Once again telling us that these are the factors affecting implantation. So when it is Figo 3, we may have to think big one you remove, and a small one, why not we give mephi for 3 months and see what happens. So, does removal of intramural fibroid affect pregnancy? Lots of studies have gone on. Nobody has said the last word beyond that, but the authors suggested that cine MRI might play a role in selecting patient who is required for surgery. This is even one more complicated investigation. Supposing a lot of movements are there by the cine MRI, then I think it will remove. I don't do those cine MRI, I just take decision on my own, and I say if I failed one embryo transfer, I either remove or give medical management. So that's how it is. So location matters, as I mentioned. Submucous fibroids, there's no doubt about that. Given the new molecular data implicating both submucosal and intramural fibroids having deleterious effect on the endometrium, no doubt these Figo 3 fibroids would also negatively impact implantation, and probably we can choose either removal or mifepristone in this kind of patient. They've also realized, talking about the contractions of the uterus, in the late follicular phase and periovulatory phase, peristalsis occurs in the opposite direction from the cervix to the uterus, likely to transport sperm to the fallopian tube. In the mid-luteal phase, the uterus appears to slow down peristalsis movements towards for the implantation, and they have found from menstruation to the mid-ovulatory phase of menstrual cycle, the uterus contracts from the cervix to the fundus with increasing frequency. That's a beautiful statement. We want the sperms to go inside, it will contract the other way around. After implantation, there should not be any contraction. So in the luteal phase, the direction of peristalsis is reversed. That means you are pushing the embryo down. Hence, the role of understanding Figo 3 and Figo 4 fibroids. Results show 34% pregnancy rates in the low frequency group, while frequency means peristalsis, compared to 0% is under peristalsis. The association of fibroids and pregnancy outcome in IUI for unexplained infertility has been proved beyond doubt that all these, the dark green on the right side, they're all with fibroids. They have significantly shown, of course, the ones which are showing improved pregnancy rate, clinical pregnancy rate per conception, is without fibroids are even better, obviously. So the other modality of treatment which we are talking about is basically the medical management itself. Mifepristone reduces the fibroid size and improves the symptoms associated with them. A lot of trials have proved this. Now this is important. I was talking to one madam just now. She was telling me that fibroid increases 1 centimeter per year, and that is obvious. But if it is increasing faster, you think about something wrong. Because the fibroids are either fibroids, leiomyomas, or it can become leiomyosarcoma. You can't ignore that point, though they say 0.01%. But now they have found different kinds of classification. Smooth muscle tumors with uncertain malignant potential. It's called a STUMP. I'll repeat what I said. Smooth muscle tumors with uncertain malignant potential also may be there. And finally, Mullerian malignant tumors can also be seen along with fibroid uterus, low-grade Mullerian adenosarcoma and Mullerian adenosarcoma with sarcomatous growth. A lot of classifications. Pathologists have made us more confusing by saying there can be leiomyosarcoma, there can be malignancy in small percentage. So when fibroids are growing faster, there is no place for even medical management. I think that case you should do surgery because you cannot take a chance. After you remove, you have to send it to the pathologist. The recent pathologists, the younger generations are classifying like this. Because the older generation, when we all became professors, that classification was not there. Now they have introduced these systems, STUMP and things like that. So when, in fact, you cannot prove which fibroid becomes malignant. But when it grows beyond 1 centimeter per year, that we all know, when 10 centimeters means 10 years it is there. Somebody is growing more than 2 centimeters per year, that uterus you cannot give medical management because you have to remove the uterus. You can always do lactodehydrogenase. Simple LDH can be done. If it's I don't know the exact value, but if it's very, very high, that is a sign of maybe getting into leiomyosarcoma and STUMP. So again, there is no place for medical management in those fast growing tumors. However, when the uterus is having fibroids and causing menorrhagia around much beyond less than 40 years, only in those cases you can give medical management. So we now know uterine smooth muscle tumors can clinically behave as fibroids. It can be benign leiomyoma, as I mentioned. So they are all coming under uterine smooth muscle tumors. That's the new classification. And benign leiomyoma, everybody knows. Uncertain malignant potential is STUMP. And malignant leiomyosarcoma, we all know. But the STUMP is something new which has been come up in the pathologists, and that also cannot be ignored. You have to think twice before you treat them. So when we talk about STUMP, smooth muscle tumors of uncertain malignant potential, STUMP is a smooth muscle tumor with features that preclude as unequivocal diagnosis of leiomyosarcoma, but they do not fulfill the criteria of leiomyoma or its variants and raise concern that the neoplasm may behave in a malignant fashion. So that's how the picture grows. Benign. In this the color is not coming, it doesn't matter. The STUMP from a benign to malignant can happen. So you cannot ignore that fast growing tumor if you find in clinical practice, and probably that's the case for surgical management. The pathologists have put all these diagrams, not diagram but the features which as clinicians we may not understand much, but they said in a tissue which has necrosis difficult to classify like tumor or ischemic necrosis, diffuse atypical with a borderline mitotic content, mundane leiomyoma with 15 mitosis, the mitosis activity is being seen, epithelioid or myxoid leiomyoma with atypism, infiltration of adjacent myometrium and atypical mitosis. I think if the pathologists tell us these things, even if you remove a myoma and send them, if they do all these things, at 45 years you can't leave her alone. You may have to do hysterectomy if there's a STUMP diagnosed. So the incidence of myoma is lower in Paris women, but not true. We have found in all kinds of age group we are finding myoma. Now what about asymptomatic fibroid? Warren treatment only in the following situation. The size of uterus is more than 12 to 14 weeks pregnant size. As madam is talking about, her patient is 12 weeks already growing. I don't think you should wait longer. Rapidly growing fibroid. Evidence of hydroureter hydronephrosis. Subserous pedunculated fibroids are liable to undergo torsion of pedicle and hence may be treated even if asymptomatic. So we now know you either don't do anything for fibroids if there are no symptoms, or you intervene with medical management or surgery management or combine. Evolution of fibroid management is a paradigm shift from total surgical management to medical management wherever feasible. Surgical management is only when there is absolute necessary to, of course, we have to always remember, save the uterus. So mifepristone is a selective progesterone receptor modulator, is a progesterone receptor modulator that has almost pure antagonist property and may directly decrease the progesterone receptor in the myometrium and leiomyoma. Mifepristone has been evaluated for reduction of symptoms in fibroids, in perimenopausal women, and in adolescent girls, and in certain infertility patients, which I have been talking about. They are unequally positioned in the treatment of fibroids. Basically, they reduce the pain, reduction in bleeding, reduction of the size of uterus, and overall quality of life. Unlike long-acting GnRH analogs, they do not have the drawback of profound estrogen deficiency causing bone loss. Even GnRH analog, you can't give for more than 6 months. You can only give 6 months because they cause bone marrow problems. So mifepristone, a pure antagonist of progesterone, may have mixed progesterone agonist and antagonist activity. Progesterone is a pure progesterone agonist. Mifepristone is most near to being a pure progesterone receptor agonist. Mechanism of action in the uterine fibroid, as I told you, decreases BCL2 expression, extracellular matrix reduction, increased apoptosis, and increased androgen receptor, decreased expression of so many things happening around, thereby affecting the size of fibroid. Dr. Alka Kripalan from Delhi and the team have published, I like this publication, though it was a little while ago, 2000, I think it was 13, if I'm not wrong, almost 12 years back. But the article clearly, madam has done a beautiful study to evaluate efficacy and safety of low-dose mifepristone in medical management of myoma. She compared 10 and 25 milligram per day, and they gave it for 3 months, and they found that the last line, of course, mean myoma decreased by 35%, and of course 22% in different groups of people, but ultimately they found the symptoms were very less at the end of 3 months. The conclusion of madam's study is mifepristone 10 to 25 milligram caused symptomatic relief with more than 90% reduction of menstrual blood. Greater myoma size occurred reduction in 25, so larger the fibroid you give 25 milligram. It can be a reasonable choice for management of uterine leiomyomas as it administered orally and cost effective and has very mild side effects. So does mifepristone cause hyperplasia? I did mention a little while ago, it does. Can be used safely. It causes certain specific changes in the endometrium. These changes are designated as progesterone associated endometrial changes and consist of cystic glandular dilatation with no evidence of atypical hyperplasia has been proved by repeated biopsies. These can be confused with the hyperplasia, but they are absolutely benign. So to conclude my presentation for you all this afternoon, understanding the molecular genetics and the pathophysiology has improved our decisions for myoma and fertility. Adolescents and perimenopause women have a very special role for medical management, which you can try 25 milligram per day for 3 months to 6 months. There appears to be enough evidence that non-cavitary intramural fibroid affects fertility. Type 3, which I have been emphasizing, infertility and embryo transfer patients may have a higher risk of poor pregnancy outcome compared to type 4. Fibroids are frequently seen, everybody seems to be having fibroid, but paradigm shift from predominantly surgical to predominantly medical mode of management, and a low dose mifepristone is one of the very good alternative for our management and almost no side effects.